Good afternoon, everyone. I'm Ali Fodi. I'm a program officer at the New York Health Foundation with our primary care priority area, and I'm pleased to welcome you here today to our discussion on telehealth. So why are we talking about telehealth? Telehealth is the new normal in healthcare. It skyrocketed during the COVID-19 pandemic, and although it's waned as healthcare facilities have reopened, we know that telehealth is here to stay as an option for patients and as a tool for providers. And we saw this bear out, this exponential increase in telehealth over the pandemic, where the New York State Department of Health in its survey said 4 in 5 New Yorkers they surveyed are using telehealth. We at the New York Health Foundation learned from our grantee partners' experiences that patients of all backgrounds, including New Yorkers of color, low-income New Yorkers from various marginalized communities, want to use telehealth, and providers are leveraging telehealth to expand the reach of their care in the midst of a strained workforce. But this is all in the context of the supports that exist. Do patients have the supports that they need to access telehealth? Do providers have a supportive environment to provide telehealth in? And so speaking of that, it brings us to the COVID public health emergency. In the COVID public health emergency, there was expansion of coverage for telehealth services that allowed for the skyrocketing of telehealth use. And now that the PHE has ended, we're seeing state and federal government reconsider telehealth policies. And so we're here today to talk about that changing landscape. So I'm here today with some wonderful experts, Jared Augenstein, Managing Director at Manat Health, Mary Zelazny, CEO of Finger Lakes Community Health, and Bob Hayes, President and CEO of Community Healthcare Network. And they're here to provide that lay of the land of the changing telehealth policy landscape, to talk about in practice what this meant on the ground for their providers and for their patients. And although NY Health doesn't conduct or support lobbying, we'll talk about policy, about the policy issues that have arisen around telehealth and around the solutions to fix those policy issues. So with that, by way of introduction, let me just say that first, by way of housekeeping, for those interested in closed captioning, you'll see a banner up at the top as well as an icon at the bottom. We will be recording today's session, and we'll send a recap with that recording out after our event. And lastly, most importantly, I'd encourage you to interact with us using the chat feature. So first of all, just let us know who you are, say hello, introduce yourself to us, the panelists, and to your fellow attendees. Put your questions and your comments in there. I will be monitoring that and lifting up those questions or themes of questions in our conversation. And with that, I will hand it off to Jared.
Great. Thanks, Ali, and thank you to the New York Health Foundation and for convening this space, and Ali for organizing this discussion. I'm really excited to be with everyone today, and really excited to hear about the kind of real-world experience of using telehealth and navigating some of the policy opportunities and barriers from my co-panelists, Mary and Bob. So what I thought I would do is sort of lay the groundwork of where we are today from a policy perspective, both at the federal level and at the state level as it relates to telehealth, kind of talk about where we've come from, where we are in sort of mid-2023 and where we may be going in the future. And I'll do that by speaking to kind of what's going on at the federal level and then what's going on broadly across the country at the state level. And it will emerge through conversation, and Mary and Bob will get into some of the specifics of New York State policy in particular. So as it relates to the federal policy landscape, I think it's kind of useful to remember that pre-COVID, there was almost no telehealth utilization happening across the country. Less than 1% of all ambulatory volume was happening via telehealth, and there were really significant restrictions in place in many states, but perhaps most importantly in Medicare, which basically restricted telehealth to only be payable when it was happening between 2 clinical sites and in rural areas. The types of providers who could deliver care virtually was very limited. There was limited coverage of audio only or telephone services, and there were other restrictions that made it really challenging to actually deliver care virtually in Medicare. During the public health emergency, many of those restrictions were lifted, and those restrictions remain lifted through the end of 2024. And many of those restrictions in Medicare are statutory restrictions, and so the flexibility that's needed on an ongoing basis needs to happen through an act of Congress. Now, there seems to be broad bipartisan and bicameral support for several different bills that have been introduced that would eliminate those barriers permanently. None of them have passed yet. And so while I'm optimistic that the flexibility is in Medicare will continue, they're not in law per se beyond 2024, beyond the end of 2024. In addition, there's been some more nuanced kind of policy making that happens annually through the physician fee schedule in Medicare. And this year, the proposed physician fee schedule came out a few months ago. It implements many components of the Consolidated Appropriations Act of 2023, which extends some of these flexibilities, provided additional flexibility, for instance, around direct supervision for telehealth services, telehealth in teaching settings, such as health systems and FQHCs, telehealth for opioid treatment providers. So there was additional flexibility provided, proposed to be provided through the end of 2024. So there's this kind of big date at the end of 24 where a lot of flexibilities are in place through December 31st, 2024, but not beyond. And so that's kind of a big policy question mark at the federal level as it relates to Medicare. So now let me shift to the states. In the states, before COVID, about 40 states had implemented coverage parity for telehealth services, which means that if a service is required to be covered in person, it has to also be covered via telehealth. And about 10 states had payment parity, which means if a service is covered in person, it has to be covered and paid for at the same rate if it's delivered virtually. Now, about 45 states have coverage parity legislation on the books, and about 20 states have some form of payment parity. Although some of those payment parities, like in New York, are time limited and also limited to certain services like behavioral health services or primary care services. Although it's an area that we expect to see kind of continued expansion, more states introducing payment parity legislation. One of the other flexibilities during the public health emergency that was really useful for telehealth was around licensure. Every state at the height of the pandemic had some flexibility around physician licensure and many other types of licensed professionals that allowed providers who are licensed in one state and in good standing to practice in another state. Almost all of those flexibilities now have been reversed, and we're kind of back to where we were pre-pandemic from a state licensure perspective. There are some emerging and evolving models, some of which have been around for longer. For physicians, there's the Interstate Medical Licensure Compact, which a few more than half of states are signatories to now, which provides an expedited path to licensure for physicians, but not true reciprocity. There are special telemedicine registrations, which are sort of light versions of licensure that exist in some states. Some state medical boards have also created flexibilities for continuity of care or for low numbers of visits from out-of-state providers. So we continue to see some kind of tinkering around the edges of licensure, but we're basically back to the fully state-based process that we had pre-COVID for physicians. There are compacts for almost every licensed profession now, and those compacts are kind of in various stages of development, which will continue to provide some flexibility. Next is sort of modalities. So how is the telehealth care being delivered? There's broad coverage now in states and in state Medicaid programs for video visits. There's, I would say, slightly less broad coverage for audio-only services. And there's increasing coverage, but probably only about half of states cover modalities like asynchronous care and remote monitoring. And we expect to see more states continue to adopt coverage and payment for those services going forward. So, just to summarize kind of what are the few policy issues that we're tracking really closely through the end of this year and next year. First is the physician fee schedule in Medicare, which will be finalized later this year. The second is looking for legislation that will either continue or on a temporary basis or permanently remove those really restrictive set of Medicare restrictions around originating and geographic site, eligible providers, and audio-only services. And we're looking for that sort of in the end of year spending package this year or next year. Continuing to see states expand payment parity legislation, continuing some expansion of the licensure compacts and licensure flexibility, and continued coverage of an expanded set of modalities. So that's kind of the lay of the land today, and what we're seeing going forward. And with that, Ali, I will pass it back to you.
Thank you, Jared. And how great to have you ground us in the fact that we were talking about 1% of healthcare services with telehealth pre-pandemic to where we are now. And the rule of the day now is we're thinking about telehealth coverage and parity, payment parity remains, but we're seeing things go back to the way they used to be in terms of licensure. So it's all helpful grounding. I did want to lift up one piece that you said around that date, the end of next year being the date by and large when many of these changes are being revisited at the federal level, because here in New York State, the same now applies. New York State Medicaid recently announced that it will extend telehealth coverage to that same date about 18 months from now. So we're all considering the fluidity of the situation here and then with the other policies that you mentioned. And also, before I pass it off to Mary, thank you for everyone that said hello in the chat. It's great to see so many folks from community-based organizations, providers of all sizes, our public sector colleagues. So great to have you. And Mary, with that, I will pass it off to you.
Great. Thank you, Ali. Thanks, everybody. I'm really happy to be here to talk about telehealth. So I just want to start and talk about our experiences and then talk a little bit about some of the areas of challenge that we continue to face. So I'm the CEO of Finger Lakes Community Health. We're a federally qualified health center program in the Finger Lakes region. We have 8 health center sites in very rural communities. And we've started using telehealth way back when no one else was using telehealth, because we were serving a population that could not get to some of the more urban centers for specialty care. And so we started out trying to find providers that would connect with us, so that if we had a patient that was sent to Rochester, which was the closest urban center, we had to drive them, because in a rural community, we don't have mass transportation like you have in some of the major cities. There might be a little bit of transportation, but it's a bus that goes around the county one time a day. And so that just doesn't help us if we have to cross county lines or people have to go to places far away, from their home. So it was a real challenge for us to try to figure out how to get these services, and telehealth was the answer to how we could connect with these providers. So we built our telehealth program with specialty care initially. So what I mean is we found other providers such as mental health counselors that spoke Spanish, because we had a lot of patients that needed language access, right, for their counseling. We worked with a pediatric neurology folks up in Rochester, because our kids who were on some pretty significant behavioral health meds, our nurse practitioners were not really comfortable dealing with some of those meds. So they'd get referred up to a specialist in Rochester. And we needed to make those connections, because the parents couldn't get up there. So how could we mitigate that geographical divide and make sure that these patients got care? Because we just kept seeing that our patients, as we referred them to specialty care, they never could make those connections. And so they just got sicker, had bigger problems. Kids had more issues at school and at home. And so we had to find something, and telehealth was our answer. At that time, nothing was covered in terms of reimbursement, but the ability to get those people access to care, our patients access to care, was huge. So we started to build that program. The return on investment was that we were able to keep our patients into good care. They got their specialty care. They came back to the primary care provider, and everything worked out really well. And we didn't have to send a lot of people to the emergency room, because unfortunately, when we have someone that needs some kind of care that we can't provide, if we can't get them into someone else, they're going to end up in the emergency room eventually. That's the problem with our system, particularly in a rural community. We don't have options as much as the more urban sites do. So, our premise was it was really important for us to invest in telehealth, because we can spend now on primary care, or we're going to spend later on hospitalization or emergency room. So emergency room is a lot more expensive than primary care. So for us, it was really important that we keep our patients in the primary care setting and give them access to those additional services they need, but not try to figure out how to get them somewhere when we could use technology. The internet was getting better. At the time, it was a little rough, but it's gotten significantly better. I've always used, those who know me, I've always used the analogy of when we started telehealth, we were at Apollo 1, and now we're at the space shuttle zooming, right? And everybody's really good at this. However, there's challenges, right? So for us, we use telehealth in multiple ways. So we use it between our sites. Let's say we have a patient that walks into one of our sites, and I don't have a provider that can see that patient. I have had our nurses, our RNs, trained at all of our sites so that another site can triage that patient virtually, so we can see the patient, and they can find a provider within our system who can see that patient. So I don't have to turn patients away anymore and say, I'm sorry, we have no one here that can see you. That's huge for our communities, because people oftentimes come in when they can get to us. And we want to make sure that when they make that effort, we're there to greet them and we can provide them services. Telehealth allows us to do that. And with all the new things that happened during COVID and the new billing procedures that we were able to use to get some reimbursement for telehealth, it was a game changer. And it was a game changer because we were able to convince others, please use telehealth, because this is really important for our patients, that they have access. And now that you can bill for those services, please connect with us, because if we work together, we can really make some real strides in better outcomes for patients. So it was important as well to our workforce. I was able to have my primary care providers were able to have great relationships with all these top specialists because they had face-to-face conversations, because we'd encourage our primary care providers to participate in some of the visits with the specialists, because it really did make a difference. And it's been a game changer in that respect too, in terms of recruiting our providers. We have state-of-the-art equipment in terms of retention. Our providers know that they're not isolated in a rural community trying to serve patients. They can reach out to whomever they have as partners in New York State to provide care for their patients. We have contracts with Rochester. We have contracts in Syracuse. We have a contract in New York City with another FQ. Wherever we can find access for our patients, we've been able to use telehealth to address those barriers. So for us, working with providing telehealth services as a part of the primary care agenda, if you will, is critical, because otherwise these people aren't going to get care, and of course they end up in the hospital. The barriers that we see, though, continue to see, during COVID, we could do a whole lot of things, and it was fantastic. We did not have to worry about where the patient was, where the provider was. We were able to provide that care. We were really careful to make sure our providers, no matter where they were, they maintained the same high standards in terms of documentation, making sure that we had the right telepresenters, that everybody was, really had safety plans, all that. But when COVID ended, of course, we had to change, right? All of us had to change when the emergency ended. And so the challenge we have now is that for an Article 28 FQHC, if my provider after hours is home and they're trying to see my patient and the patient's at home, I can't bill for that visit. So I'm telling my patients, you have to get to me, or I have to get my provider to me, and my provider can't get to me for whatever reason. So I'm sorry if you can't get to me. We're gonna eat that visit, and we don't have that ability on a big scale to eat a lot of visits because we're just challenged financially, right? And secondly, one of the big problems is that Article 28 FQHCs are not allowed to have their providers, be in other locations unless the patient comes to our health center. Well, in a rural community, we're trying to provide access. So if they're at home, we're happy to be able to try to make those connections. But if either the provider or the patient is not in one of our sites, we struggle. But if I'm in Article 31 or 32, those patients can be seen. The provider can be at their home. And so it's confusing for our patients because we're all seeing the same people, really. The FQs and the 31s and the 32s, our patients are all of ours patients, right? And we do partner a lot. But these rules don't make sense because it's good for some and not for others. And it's hard to try to explain to our patients, how does that work? So we really believe that with telehealth, if you invest in telehealth, if you allow telehealth to progress and not worry about some of these, what I would call a little bit archaic rules in terms of how those visits happen, we're going to keep people in primary care. We're going to be able to sustain the primary care system, which is really critical. And we're going to be able to have better health outcomes because we're going to keep people out of the hospital. We're going to have better health outcomes for them. Thank you so much.
Thank you, Mary. You really brought that to light in talking about what it means to be able to connect among your providers across your network or to specialists. It really underscores what this can mean for patients who are just trying to seek the care that they need. I want to offer one point of clarification for folks that aren't steeped in healthcare like me. The Article 31 and 32 clinics are mental health clinics. And so when we're thinking about federally qualified health centers compared to mental health clinics, there's the notion that there's, like Jared talked about, an originating site requirement where a provider or a patient has to be in the clinic to receive care, rather than if you're a mental health provider in other settings. All right, with that, Bob, I'm going to hand it over to you, but let me first compliment our attendees. We've got a lot of you saying hello, and I appreciate it. Now I want you to start posing some questions and some comments, because after Bob's done, we're going to lift those questions up to all of our presenters. So with that, Bob, please take it away.
Okay, thank you, Allie. Great job you're doing keeping us in line here. So I appreciate it. So Community Healthcare Network is kind of the opposite of Finger Lakes. We are very urban. We're throughout the 4 of the 5 urban boroughs of New York. We're not currently in Staten Island, but we're in all the poor neighborhoods and all the poor urban communities that we serve. And since I'm representing the urban side of this discussion, I am going to hammer some of the points that Mary made, only not nearly as polite and civilized, Mary, as you did, especially that originating site business, okay? Quickly, before the pandemic, unlike a rural network like Mary runs, we were pretty limited as Community Healthcare Network with respect to our telehealth. Primarily, it was in psychiatry. Primarily, it was site to site within CHN, but also we would provide psychiatric telehealth services to places like Care for the Homeless, at shelters and places like that. And 2 things we learned. 1, it really worked. And 2, when we did surveys of our own patients, they preferred it. I joked with our psychiatrist, well, maybe, you guys don't have the best bedside manner, but fundamentally the ease, comfort, and even to some extent the professional distance seemed to make our patients prefer it. But it was very limited. Obviously, the world changed. We all pivoted rapidly, in some cases miraculously. And this telehealth, I mean, bottom line, is a very, very good thing. Obviously, we've early in the pandemic pivoted to a lot of telehealth for medical visits over time because of the importance of face-to-face for medical visits. That declined, and now it's probably still about 20% telehealth for medical visits. But what I really want to talk about is behavioral health. because that is where telehealth really does work its magic. And it's also where New York State currently is strangling behavioral health care for people who are underserved, communities of color, and are doing the opposite of what everyone in Albany says they want to do, which is ease health inequity. We're not lobbying. Don't worry, Allie, I'm not going to go any further, but we're going to talk about this policy failure. In our world, we spent a lot of time as a primary care, federally qualified health center, recognizing that integrated care was the most important thing we could deliver to our patients and to our communities. That meant building behavioral health as full partners in the holistic care that we'd be giving to our patients. So we hired psychiatrists, we hired social workers, licensed certified social workers, and basically the psychiatric and the therapists, the social workers, complemented the primary care. To some extent, the psychiatric providers work to support primary care providers in delivering behavioral health care, right? In other cases, for tougher cases, like psychiatrists, the psychiatric nurse practitioners are hands-on, and the therapists complement the whole patient care. And it was working. It grew and became more prevalent during the pandemic as nearly all of behavioral health pivoted to telehealth. Not completely. There were times when it was clinically, like I said again, clinically necessary to do face-to-face. You know, psychiatry, there are injectables. Sometimes you do want to have a therapeutic relationship that is renewed with a face-to-face visit. So that we were doing, but it was done based on the patient's clinical need. Come the end of this public health emergency, and it's what I'm going to hammer on, things changed. As Mary said, suddenly either a patient or a provider has to be on site. What that means is for no clinical value, since patients do not want to come in having enjoyed the convenience and the ease of telehealth, it means you have to bring the provider in to sit in a health center to do televideo sessions with their patients. We're in a workforce crisis. We're in a workforce crisis, particularly in places like community health, where we already have our hands tied behind our back because we can't pay what is paid in commercial practices and private practice. We can't pay the kind of behavioral health salaries that are typical in practices with people, for patients who generally have needs, but not the acute kind of needs that our communities are facing. And suddenly we are mandating that under state requirement, our psychiatric and therapeutic providers come in and sit, in a stuffy room, commute, and are doing telehealth. What that means, and the folks I know in the audience know the specific details, but we are down about 30% in staffing, and therefore 30% in access. And we have a public health system that is very pious in its insistence that our high priority is to bring health equity, particularly behavioral health equity, particularly in this era when as we continue to deal with trauma, not just pandemic-induced trauma, but urban and rural trauma across the state. We are, I've used the word to the state Medicaid director, strangling our behavioral health capacity because of what really is a clinically unnecessary, if inappropriate. It's actually inappropriate because, as Mary said, things like patient convenience, no-show rates, all are so much better when you get to providing telehealth. So, at the end of the day, we are, not going to be able to maintain a behavioral workforce for low-income folks when we are competing for the same employees with, every time I hear another telehealth startup talking about therapy, talking about call us up, they're all over public radio promoting their services. Every time I hear that, I see that's the kind of places that are going to be thriving and they're going to be more successful in recruitment simply because we have been further handicapped, if you will, in our ability to compete. As I said, it's already been tough. You already have amazing, terrific people who want to make the commitment to provide services in these communities. But right now, the state of New York is making it tougher and tougher. So I will stop there, Ali, and I did not lobby.
Thank you for that. No, you did exactly what we wanted to do, was just shine a light on some policy issues and opportunities to fix them. And we actually have questions to that effect. So I'm going to pose this to you all as the policy experts. To the extent we can't dig into this totally, we will make sure to connect our attendees with resources on this. But we had been talking about the limitations on Article 28 clinics, federally qualified health centers, namely around these originating site requirements. And so we got some questions in the chat around, on the flip side of that coin, Article 31 clinics, to confirm that these providers can conduct telehealth services remotely. So that's the first question. And then secondly, are the originating site requirements, is this permission for providers to be at home to provide remote care only applicable for OMH licensed facilities, or what I'm assuming from this question is behavioral health providers more broadly?
I'll start. Article 31 and Article 32 organizations, this rule does not apply to them. This is specifically for Article 28, I think just FQHCs. I'm not sure about private practice, Article 20, or, hospital practice 28s. But OMH hasn't changed. They've been consistent with these rules. They've actually have done a really good job, I think, with some of their rules and how we can access patients and how patients, more importantly, can access us.
I would say there was a time when Community Healthcare Network actually had sites that were licensed under 31 and 28. Jared, you may know much more about this than I do, since I'm at 30,000 feet licensing issues. But basically under 28, you can provide up to 50% of your services as behavioral health.
Right.
Giving comprehensive care to our patients in an integrated setting. I think it's really good for the behavioral health provider to be down the hallway physically or telephonically from the primary care provider. Coordination. So we eventually just gave up our 31 licenses, unnecessary paperwork. So we may not be serving the most acutely ill psychiatric patients at the community health center, but we are providing very similar services, and yet are being strangled financially by this rule applying only to 28.
Bobby, will say you got muffled there in the end, so perhaps you wouldn't mind just leaning a little closer and summarizing what you just had to say, because we lost you for a bit there.
Okay, I'm saying that the services provided in Article 28 to behavioral health patients are in most cases comparable to, equal to those provided in Article 31, with the exception, I think, that in some ways it's better in an Article 28 because you're integrating the primary care provider with the behavioral health provider.
Okay, thank you all very much. And also thanks to everyone in the chat. You've been sharing resources and offering your own experiences in clinic, so appreciate you allowing us to all learn from one another in this respect. My question for you all, Mary, I wanted to pick up on a phrase that you said around a game changer, which is you had mentioned that reimbursement for telehealth had been a game changer for Finger Lakes Community Health. And so I'm wondering if each of you can articulate what you think has been one or a few of the game changers in terms of policy changes that have allowed for telehealth to become part of the healthcare delivery landscape, and what game changers are still out there that we don't have in practice, solidified in policy here in New York.
So I would say the biggest game changer happened, and it was published, I believe, in the February 2019 Medicaid update. But that came out of one of the committees that under Governor Cuomo on telehealth to redesign the system. And it was when that gave us the ability to have patients not have to come into a clinical setting to get care. That was huge because people can't get to the doctor all the time, right? And they might be at their sister's house on a couch, or they're in a homeless shelter, or they're somewhere here in, in our community, and they have no access to us other than if we can find them and get to them. So to me, that was the biggest change that came down from New York State. And it was fantastic. And, that opened the door. And right after that, of course, COVID hit, right? The next year. And we didn't have to worry about that, right? That was already set up. So that was fantastic. This issue of the originating site is very challenging. It really puts us in a difficult position with patients, not being able to provide those services the way that they need them. Because we did that for 2.5 years during COVID. Everybody got used to it, and all of a sudden, nope, sorry, we can't do that anymore. And I think we need to just really reevaluate that, because we need to keep people in primary care, and by providing full access and using telehealth technologies as our tool is of huge benefit, and it will ultimately save the state money because it's going to keep people out of the emergency room.
Yeah. And I would say one of the great improvements, Allie, game-changing, that's evolved and continues to evolve by necessity, is the technology. Early on, we kind of figured out we had plenty of our own problems on the provider side in doing telehealth visits, but much more so in our patients trying to figure it out. Trying to find the difference between the telephone, the video, and ultimately the broadband. Still a problem, but I've got to say that, in part, the rapid sophistication of our communities, and there have been public policy pushes, including by, the state's, I'll say something nice, Economic Development Corporation, to try to actually increase broadband across the states, probably acutely in some of the urban areas, but also I'm sure up in the Finger Lake areas. That's important. It's going to keep getting better. It's going to make what Mary just said all the more important, because it will increase the quality of the care that we can provide through telehealth. And, along with remote monitoring, 15 other things that technology actually is making work, is something that I think we can celebrate.
Right.
Yeah, and I'll say, maybe since Mary and Bob focused on the state level, from a federal perspective, consistent with Mary's answer in the 2019 report in New York State, I mean, the lifting of the geographic and originating site restrictions in Medicare is really huge. I mean, that's just unlocked kind of national access to care from the home. And, the thought that in 2023, telehealth would only be paid for between a clinical setting and a non-clinical, or 2 clinical settings, is kind of antithetical to the whole concept of telehealth. So, I think the biggest, game changer going forward is going to be permanently lifting many of those originating site restrictions. And then, maybe to build a little bit on Bob's point, I think the technology is getting better at a rate that, I don't even think we're all kind of realizing. And this is also happening at the same time that more and more care at increasing levels of acuity can and should be shifting to the home, because if you look at all of the survey data, it's what we want as patients. And so we've been talking a lot about kind of primary care, behavioral health, and specialty behavioral health services, but there's also this big shift to providing complex care in the home, and even hospital level care in the home. And states are way behind that trend. Medicare has been paying for hospital in the home for many years now through the pandemic. There are only a handful of states that pay for hospital at home services in Medicaid. And so I view that as kind of a big opportunity over the next few years. There's no reason that you should only be able to receive hospital level care, in the home if you have one insurance and not another. The results from those programs have been incredibly, impressive, both from a cost perspective, from a clinical quality perspective, and from a patient satisfaction perspective.
Jared, well, thank you all. Jared, to that point, because you started alluding to other states, I'm wondering if you could lift up for us, outside of New York, are there other states that have made telehealth policy changes permanent, or they've even adopted new models that have gone beyond pandemic era policy changes that you think are particularly innovative in preserving access to virtual care or even expanding access?
Yeah, and I can talk to two states where we've been doing a lot of work directly in North Carolina and California. Every state's different, but every state's kind of in some stage of figuring out like what do we keep and what do we not keep from our pandemic era flexibilities. The Medicaid agencies in North Carolina and California have both taken a really kind of thoughtful, methodical, data-driven approach to this. And just to give some examples, in California in particular, we haven't talked a lot about the audio only issue, but there are huge broadband deserts across the country, and not just in terms of can you access broadband, but can you actually afford broadband, and do you have data caps on the cell phone plan that you're using? There's really like practical barriers that get in the way of accessing video visits for many people. And so California has a policy of paying for all services that are covered in person in Medi-Cal are broadly covered in telehealth, including for audio only, and paid at the same rate, recognizing that we shouldn't be disincentivizing providers from delivering services just because a patient isn't able to access a video visit. So that's kind of some of the forward thinking that I think is really important, and is going to allow states that take those approaches to sustain access to telehealth services and access to care in general, and not risk losing some of the gains as Bob and Mary highlighted, maybe a risk here.
That's great. Thank you so much. And Jared, I'm glad you brought that up, because philosophically, you're talking about audio telehealth as a means to advance health equity or combat disparities. And that harkens very much to what Bob was saying. But then also it dovetails very nicely with a question we have in the chat, which is around connectivity, and thinking about, like you said, patients having barriers to accessing broadband or other forms of digital connection to use telehealth in ways they might want. And so I wanted to pose the question of connectivity to you all and barriers to seeking telehealth. How have you seen this play out with the patients that you serve or those that you're hearing about, in terms of what have been the supports on the ground that you have used or leaned on to support patients in using telehealth? Or what are the policy changes that you have seen be helpful to help overcome this digital divide for patients to seek telehealth services? And anyone can go first.
I'll just say we have seen remarkable progress. Okay. I do credit most of that progress to incredibly patient providers, working and maybe not working as quickly as our finance department may like, to help the patients connect for the visit. But over time, it does seem to be a very successful pivot. We did lean on audio only early in the pandemic. We shifted quite rapidly, and that did create problems. It also created problems, and again, I'm going to stick a little more with behavioral health, which may have more sensitivity for patients. A place to be to do a telehealth visit is important. And, most of our patients don't have those beautiful fields like they have up there, Mary, in the Finger Lakes, to go take a call. So the privacy issue was real, and that was actually easier with audio only. But I'd say that we have almost exclusively shifted to telehealth video visits at this point. And not great, but we're getting there, and remarkable day and night compared to 18 months ago. Mary?
Yeah, so we've been able to maintain about 30 to 35% of our visits across our medical, dental, and behavioral health services are done through telehealth. And, for us, we really, when the pandemic hit, and there's this huge switch and everybody was like, okay, you got to turn a camera on. So we took a couple of our staff members and created a team that literally called our patients on the phone and said, you have a Zoom call tomorrow with your doctor. let's make sure you got Zoom loaded on your phone or on your iPad or computer. And would you like to do a mock call so we can get that out of the way so that we don't interfere with the care that you want? And we found that that was a huge game changer for our patients in that respect, because they were comfortable and they knew that they had someone they could call. It was a lift for us, but it really just did work out in the end, because we heard a lot of people say to us, you're not going to get your seniors to use telehealth. And we're like, gee, we don't have that problem, right? And so we have found that, the equipment, to Bob's point, the internet connectivity is so much better. There's still gaps here out in the rural communities, there's no question, but they're rapidly shrinking. And our biggest problem is we have a lot of hills. So that's, we have to get around that. But what we've seen as people with their iPhones, that particularly, we see a lot of farm workers out here. We have some special funding for farm workers, and they didn't miss a beat with telehealth because they had their cell phone. So we've been working with our patients to educate them how to use that technology. But what we've also done is tried to find places where we could put equipment that would provide a private space for our patients, because they can't maybe get somewhere else, and they can't be at their house because we have, we'll have a pretty extensive families living in one house in some of our rural communities. And so we've started putting little telehealth hubs in different locations, like the library. So a little room that people can go in and they can do their thing and have their appointment, and then not have to worry about some of that confidentiality that Bob mentioned, because that's a huge problem, especially if you're talking to a counselor and you don't want everybody hearing what's going on in your life. So the equipment has been a game changer. It has changed. And one of the things I say to people all the time, you do not have to go out and buy $40,000 telehealth equipment. About a $60 camera from Staples is fine, and it works. So you don't need all this fancy stuff. It's not the equipment, it's teaching your staff and modeling good processes and policies to make your program work. And it's great for our patients.
And just to show how far we have evolved. I mean, we've been 5 people on this call for the past 50 minutes almost, and no one has yet said, you're on mute. See, we're learning.
No. Yeah, that's a thing.
Great. And Bob and Mary, you both talked about a number of barriers that patients face, the tech of it all, the digital divide, the devices and the connectivity, but also confidentiality and privacy issues and otherwise. So it's worth knowing that these are real barriers that patients face. And yet you, Mary, talked about navigating, telehealth navigation to help patients use these tools. I'm going to take a moment to brag about all of our grantees and partners, you all included, but Health and Hospitals, we've supported them to do some wonderful work on patient navigation. Sun River Health Center with Air NYC, Engage Well, and the Alliance for Positive Change. We're really learning that with the support of a trusted professional to help patients understand how to use technology to gain a level of fluency, that telehealth is an option that patients want, provided that those barriers can be mitigated. So it's great to learn that you've charted the course and you've really seen the innovation in this way. There's been a great amount of activity in the chat. A lot of it is very particular policy issues. So I'm going to lift those up to the extent that you all can answer these questions. And then if not, we'll make sure to connect our attendees with resources. There was a question around commercial insurers and coverage for telehealth. So Jared, I'm wondering if you can talk about examples where you've seen in the commercial market relative to Medicare or Medicaid coverage for telehealth lapsing or changing in a way that's worth noting.
Yeah, I mean, so as I mentioned, about 10 states pre-pandemic had payment parity, legislation which required state-regulated commercial insurers, which in many cases includes the Medicaid managed care plans, to cover telehealth services at parity with in-person. Now that's about 20 states. Many health plans also voluntarily committed to paying for telehealth services at parity during the public health emergency, but we've also seen now many commercial insurers in particular kind of scaling back their coverage of telehealth services, and in states that don't have broad payment parity, paying at 70 or 80 or 85%. what they're paying for an in-person service. And if you're operating at a 1% margin or a 5% margin, like most practices in the country do, you're not going to be able to cover your costs for providing that service, and it creates a real sort of financial disincentive. And all of this is also only, all of the payment parity legislation only relates to state regulated plans. So the ERISA plans are exempt, and that's a whole kind of separate issue. I mean, half of the population is sort of covered under an ERISA plan, so that's a big carve out where there are, plans are not always paying at the same rate, and there's a lot of kind of plan discretion, and we've definitely seen in certain markets, plans paying it at significantly less than the rate they're paying for an in-person service, and providers, not able to continue offering that service because they're not able to cover their costs.
What I'm about to say clearly applies to Medicaid, but it should apply to many commercial payers as well, especially any payer that has more than like 1 year at a time with a group of patients. Anything that Medicaid can do in New York to ease access to primary care, and by primary care I'm including basic behavioral health care within that definition, is going to be in a financially improved position than not making it easy to get primary care and paying those hospital and ER bills. I mean, it's really nice sometimes when the humanitarian common sense argument aligns easily with the financial argument.
Exactly.
Thank you all. See, just a few more questions in the chat that I'm gonna lift up before we have to part ways. There's a question here around the New York State budget and the telehealth provisions that were enacted in the recent budget. And I'm wondering, Mary and Bob, can you give us a sense of the telehealth policy changes that we saw at the state level and what that's meant for the care that you're providing?
Go ahead, Bob.
Okay, thanks a lot. One of the things I do in kindness to myself is not read state budgets directly. But I did see that question, which I really can't answer specifically as you pose it, Ali, but it's why I said what I said, that any budgetary consideration should do everything possible to let me and Mary hire the medical and behavioral health providers to keep people healthy and the hell out of the hospitals, which is where all the money goes down the drain, sadly. I don't mean that exactly, but you guys know what I mean.
Yeah. We've come a long way. And, kudos to New York State, because I travel all over the country for work. And I will tell you that we are in good shape for the most part in a lot of things when it comes to telehealth compared to other states. However, I think too that some of these new rules that came out once the budget and once the public health emergency ended and the budget came out, this business about the originating site, I mean, we were all just really finally building our telehealth capabilities right across. Everybody jumped in COVID, and then about a year in decided, okay, we really have to figure out the best way to do this, and to really build these capabilities into our current system of care. We got to really pay attention to our policies and all that stuff. So a lot of people did that work, and then we kind of got cut off at the knees a little bit when all of a sudden they changed the rules, and it impacted us, but it also impacted our patients. And so those kind of funky rules that all of a sudden we have to make sure that our teams understand, and then also our patients understand, why do I have to not go to my behavioral health appointment, but I have to come into you? What's the difference if you're all seeing me for my healthcare? Those things are hard to explain to people. It's hard to explain to staff, and it really does put pressure on us when we're trying to find any way we can to keep people in primary care, because we know it's less expensive.
Thank you. All right, last question, and I'm gonna ask us to dream big for a minute about the future of telehealth. So in each of your perspectives, from a policy perspective, as administrators and clinicians, what is the ideal mix of care to serve patients in the ways that they clinically need and in the ways that they want, that meets their needs and preferences? The ideal ways that telehealth can be complemented with in-person care to meet your patient populations.
I'll say that, I mean, patient choice is pretty important. It's not the complete answer, but getting a patient to a provider is the #1 hurdle to good health. So yes, a good provider will recognize that telehealth may be an opening door, and there may well be other needs, including a number of face-to-face encounters, whether it be medical or behavioral. But to have that tool of ease strikes me as the future of improved healthcare, especially among communities where there isn't the embrace of running to the doctor with every sniffle. We're not encouraging that, but we are encouraging folks to really take care of their health preventatively, and telehealth is a great tool to advance that cause. Mary?
Yeah, I would just comment, if you think about, not every visit is right with telehealth. There's no question. There's times you have to go in and you have to touch the patient, then the patient needs to be in the clinical setting. There's no question. But if you combine the beauty of telehealth and the ease of access for patients and the access to care with in-person care, and I'll take a senior citizen, for instance, if you have a 80-year-old woman who is maybe diabetic and she's getting her care, well, she needs to have a checkup. She needs to talk to somebody, because you want to check in with them routinely to make sure that they're checking their feet, that they're taking their medicines, all those things. And of course, with diabetes comes depression. So you want to have that connection. But I don't want her driving in the wintertime to just come talk to me as a provider, when I'm not really going to touch her necessarily, maybe shake her hand, but I don't need to see her in person. Those kind of visits can mitigate problems. If she gets in her car, she drives, it's snowing out, or she falls, she slips in her driveway. There's all kinds of things that can happen. So I think that if we can combine the technology with in-person care, and frankly, young people, they want their healthcare like they want their banking. And they don't want to necessarily come in all the time the old way, where you sit in the waiting room and then you go into the room and wait for the doctor to come in. That stuff doesn't have to be that way. It can be much more streamlined. And when you streamline the system, it becomes more efficient and cost effective.
Yeah, I agree. We've done kind of some work with the AMA thinking about the concept of digitally enabled care, which I think Mary and Bob, the way you described it, syncs up nicely with that. I mean, I'll just maybe leave with this, which is, we've become so anchored to this concept of a visit. And we talk about, like, is the visit in person or is the visit video? And we need to do away with like this concept of a visit and think about, episodes of care and kind of care experiences, and there being many different ways that a patient and a team of providers interact, some in person, some by video, some by phone, some by text message, some cases where data is being transmitted to a provider and they're able to detect whether there's a need to be seen in one of those other ways. I mean, that's clearly how care is going to be delivered in the future, and the more we can kind of support that type of care model from a payment and policy perspective, I think the better we'll be able to deliver the type of primary care that Mary and Bob, you noted is so important.
Yeah.
Wonderful. Thank you all for speaking in such real terms about what this means for patients, resonant terms in ways that steep us in your expert knowledge of telehealth. I have found this incredibly informative. I hope attendees, you all have too. And thank you all for offering your thoughts, your questions, your resources into the chat. It was great to see all the knowledge and thoughts exchanged here. Thank you all for joining us. Mary, Bob, Jared, thank you for participating and offering your expertise. Again, as a reminder for everyone, we will be sending out a recap of today's session after this, and we encourage you to stay connected with us. New York Health Foundation, me, Ali Fodi, and otherwise, and all of our presenters here today, to keep tabs on what we're all doing in virtual care and otherwise. So thanks, everyone.
Thank you.